Hi everyone, my name is Claudio Peru. I'm the Principal Endodontist at UK Dental Specialist. And welcome to the UK Dental Specialist podcast, your go-to source for all things dentistry and beyond. From essential patient information to exclusive interviews with some of the most influential figures in the dental world, we have got you covered. Whether you are passionate about oral health and want to understand how to achieve your best smile, or you are a dental professional looking to stay ahead with expert insights and clinical perspective, this podcast delivers knowledge, inspiration, and motivation to help you thrive. Join us on this journey as we dive into the latest trends, inspiring personal stories, patient-focused advice, and everything happening in the world of dentistry. Welcome to UK Dental Specialist Podcast, where expertise meets excellence. Hello and welcome back to the UK Dental Specialist Podcast, the show where we dig into the real stories and insights behind modern dentistry. I'm your host, I'm Claudio Peru, I'm the principal at UK Dental Specialist in St Albans, and today I'm joined by my colleague and friend, Dr Pranay Patel, a CGC-registered Specialist Prosthodontist and an integral part of the UK Dental Specialist team here in St Albans. So Pranay's scope of work covers all the prosthodontic spectrum, from aesthetic bonding and full mouth rehabilitation to complex implant restoration and high quality dentures, which these days are not as popular as they used to be. They are steadily becoming a bit of a lost art, and we will touch on those as well. So in this episode, we will talk about what really means to practice comprehensive dentistry in 2025 and how to approach implant safely, and with what young dentists should know before diving into aesthetics. I think that's a very big subject at the moment. And I thought that would have been a good idea to cover pitfalls in treatment planning. So something that hopefully the listeners can take to their practice tomorrow. And I think also, very importantly, how Pranay balances family life with a demanding clinical career. All of us, we've got family back home and we're very busy in practice. And there is always sort of a balance we need to strike between full attention at work and then all of a sudden full attention back home, and another day we start. So grab a coffee, settle in, and let's get started. Now, Pranay, thank you very much for your time.
Thank you for having me.
It's always a pleasure. So we work today together, so it didn't have to travel very far. Now, tell us a little bit, Pranay, about your journey to prosthodontics. I think that would be a very good way to start understanding you in a professional manner.
So I qualified from Cardiff University in 2010. And I did a year of vocational training, followed by a year in hospital as a max access HO. Went into clinical dentistry as an associate for a couple of years, and then got into specialist training and finished that in 2017. And I did that part-time while working at the same time. So 2 days in practice, 3 days in the hospital.
Guys, right?
Yeah. And then from then, just slowly worked my way up to doing specialist treatment.
So I think it's quite interesting. And that is often one of the questions I get from dentists, not necessarily young these days, but I get messages from dentists that want to consider specialist training. So you have done, between your BDS and starting to focus on prosthodontics, you had about 4 years,
3 or 4 years.
3-4 years
before starting training. Yeah.
So looking back, do you think those years of general dentistry were useful, or do you think, it would have made no difference, I could have done a BDS, go straight to specialist training, or do you think that touch with reality helped you?
No, I think that you need that touch with reality, because at the end of the day, you've got to learn the basics. And in some ways, it's always good to make mistakes. So you going from BDS to your VT to specialty training is not, you don't know the basics of dentistry. You don't know how long it takes to do certain things in the outside world. You know, you've gone from taking an hour and a half for a filling or two hours for a crown prep when you're in the hospital to needing to work faster.
Right.
And when you have to do prosthodontic work, sometimes you're doing multiple teeth, you know, taking a long time to do all this work. So you need to improve the speed as well as the finesse of it. And the only way you're going to get to practice this stuff is in general practice. So if your crown preps are not the greatest, which no one's ever is when you start coming out
of your career.
of undergraduate, you build on that in your general practice, working on the NHS, you know, and then refining that, and then that will then put you in good stead for specialty
Do
training.
you think those years might help you? Because I talk about myself personally. So I work in general practice for a few years before focusing on endodontics. And I think in prosthodontics, you've got a broader spectrum of dentistry that you cover compared to us. But those years in general practice, for me, they help me to understand what goes on out there in general dentistry. So definitely they help me to relate better with my referring colleagues. Do you feel that's the same? Do you understand better?
You understand what your referring colleagues are going through, you know, whether it's a 15-minute checkup or a 10-minute checkup versus a 20-minute filling that they do on the NHS. The time, you understand the time pressure they're under and how much they can talk to a patient in 15 minutes as well as doing the checkup.
So much they can
you know?
do.
So
right?
there's only so much you can talk about and to explain stuff. And it does put you in good stead, because you're not then, when the patient comes in for a consultation, going, oh, why wasn't this done? Why wasn't this done? Why wasn't this? You're trying to be a bit more gentle, a bit more, you know, open to understanding why certain things are happening.
So you work together. And you know the limitation of the system that makes everything a little bit more difficult. But I think this is one of the controversial subjects. And I love these podcasts because they are a little bit off the record, but actually we are recording all this, so they're very much on, recorded. But I like to think that is an informal talk, and we can say things that not necessarily we would say in a lecture. But that's the controversial question for you. So loads of dentists, these days, much more than back 20 years ago, they skip the the NHS dentistry, apologies, step, and they go, as you know, straight into cosmetic and bonding and straightening and bonding, whatever they call it these days, but the aesthetic thing. So do you think that there is a place for NHS dentistry for young dentists to sort of build their skills, or do you think, actually that is not that useful?
No,
what's your view on that? You're listening to the UK Dental Specialist podcast. If you're a dentist or dental professional looking to enhance your skills, explore our UK Dental Specialist courses, from hands-on composite bonding training to advanced endodontics and much more, led by experts at the top of their field. And for patients, join us at one of our open days throughout the year to meet our specialists and learn more about the treatments that could transform your smile. Find all the details and upcoming dates at ukdentalspecialists.co.uk. Follow our social media, Instagram, Facebook, YouTube and TikTok. Link in our bio. Now, back to the podcast.
No, I think NHS dentistry is very useful for the younger generation of dentists coming out of dental school to hone their skills and understand what general dentistry in practice is all about and how to communicate with patients and so forth. I find it very difficult to, and this may be me personally, to be like, okay, got a private patient here, I've just come out of dental school, I'm going to charge £350 for a composite filling, when I've been doing a composite filling for 1 or 2 years. We all make mistakes. We all need to learn how to and adapt how to improve our treatments, and the NHS is a wonderful way of doing that. You can build your private portfolio up while doing NHS treatment and understand the whole broad spectrum of dentistry, not just composite bonding and aligning and bleaching, because if you don't understand things like occlusion, things are always going to go wrong.
Yeah, no, I do agree with you. I mean, I'm sure you agree with the fact that, some of our colleagues that will disagree with that.
Yeah,
I
there
do
will
share
be,
your view. I think NHS dentistry
and
is
we're all open to our own opinion.
absolutely. For me, it was, just really opened my eyes about, real life dentistry demands of pressure, working within a system. Personally, I think that long term is such a difficult system to
Yeah,
work
no, I agree. Once you've got the
with.
skills, I
Yeah.
think to try and do very good dentistry is really
It's
difficult on the
really
NHS.
difficult,
But
and it's possible.
as a
I know
learning
some
curve,
NHS dentists are absolutely
but as a
amazing,
learning
but
curve, it's a very good place to begin.
yeah, I wouldn't be able to do many UDA spending 2 hours per root canal. I mean, I would.
I don't think I'd get through a checkup in 15 minutes.
Yeah, any practice that would hire me, NHS practice would collapse and go bankrupt within a few months. In terms of this trend about young dentists going into like the aesthetic, do you think that they're missing out in terms of the very basic? It sounds so patronizing and probably gives out my
It's not
age as
meaning
well.
to be patronizing. That's the thing. We're trying to encourage our younger dentists to improve their broader knowledge of dentistry.
Right.
If you go straight into a line, what do they call it? A line bleach and bond? What is it? AAB
You know, but
or
I do,
ABB
yeah.
or whatever it is. That they forget necessarily how to necessarily or diagnose certain other aspects of dentistry.
Yeah.
So your whole scope of practice becomes that. And then when something different comes along, if you haven't had that experience, how are you going to be able to diagnose and treat that?
Yeah.
So as a dentist, you have to have a basic foundation of being able to provide a diagnosis. Okay, you may not want to do that treatment. You can choose to send it to a specialist, this and the other, but you need to be able to diagnose what the issue is.
Right. And do you see that sometimes? Because we have seen, especially UKDS, occasionally patients that had extensive treatment, for example, composite bonding, when things go wrong, and then they seek a second opinion, and the veneer is chipping and stuff like that. Do you see sometimes like one of the reasons being planning? And
Yeah, 100%. Prosthodontics is all about planning.
Where does it go wrong in this case?
Prosthodontics is all
normally?
about planning. Whether it's cosmetic or whether it's functional, it's all about planning. If you get the planning right, you'll get the treatment right.
Right.
And yes, there will always be issues potentially along the way, but if you plan things right, radiographically, occlusally, study models, wax ups, things like that, you can plan for your failures. You can understand where things are going wrong and
share it with the patient and say, hey, this might happen.
look, okay, with the way your bite is, this is potentially not an ideal thing. However, we can do it as a temporary measure and then work from there.
Right, so
and
stage approach.
Yeah, and they're understanding then that, okay, this one might only last me a few years, but at least you've got that patient on board.
Yeah. So on that same subject, which is another area where loads of especially young dentists are attracted by, is obviously dental implants, right? When do you think a dentist should, in their career, think, okay, so I really want to narrow my sort of field of work a little bit and concentrate on implant training? Anytime, straight after BDS, 5 years, 10 years, or there is really no time?
I wouldn't put a timeline on it, because I think as an implant dentist, you have to understand certain things.
Yeah.
And whether you understand those things in 2 years or whether you understand those things in 10 years, everyone is different.
Right. So aesthetics, occlusion.
Yeah. So you need to understand that the implant needs to be prosthodontically driven. So the crown, you have to decide where the crown goes and then place the implant dependent on that to get yourself the perfect restoration. You need to understand, you need to be able to take any tooth out.
Right.
Yeah. You don't want to be an implant dentist. Someone sends you an implant to do and you fracture the root and can't get the rest of the root out.
So good surgical skills.
Yeah, good surgical skills, good treatment planning. But then on top of that, being able to manipulate soft tissues very well, again, going back to the surgical phase, but also understanding occlusion, because your implant will fail if your occlusion is not correct.
How? What sort of failures would you see?
So, I mean, we've seen a few of them where you leave the implant crown too high.
Yep.
And your porcelain breaks, or your abutment breaks, or your screw breaks. And, really, occasionally, you will even get bone loss around the implant and fracture of the implant because of occlusion and parafunctional habits.
Right.
So, you need to understand a broad range of things to do implants. You need to understand that periodontal disease affects implants. So you need to understand how to diagnose periodontal disease to make sure that they haven't got periodontal disease prior to placing the implant. So
it's all sort of
you need
all
to have
dentistry around
exactly,
the
and
implant
it goes
before
back,
the implant.
yeah, and it goes back to having that experience to be able to make a good assessment of a patient and say, right, I've got a checklist. I've checked through perio, I've checked through caries, I've checked through this, I've checked through that, and then going to the implant, then making sure I can get the root out properly, and understanding
good
this
protocol
is
that's been tried and tested.
So there's no timeline on it. It's just
Before this, do you think now all these, fancy digital planning and workflow, have they changed how we plan and restore and place? Or do you think more or less is what we used to do, but
I think it
better,
has changed.
Okay.
I mean, if we take here, for example, Rajiv is starting to use a lot more.
By the way, for the listener, that's Rajiv Patel, our
He's a periodontist
specialist
that places
periodontist,
implants. He's starting to use a few more surgical guides.
Okay.
You know, on the trickier aesthetic cases to help me, well, to help him understand where I want the crowns to be placed and so forth. Now, previously he used to do that anyway, but not necessarily with a surgical guide. He knew where to place these things. But if you're if you're a newer implant dentist, then doing a digital wax up, constructing a surgical guide from it, using a guided drill kit means that your implant will go in the perfect position.
You would take a scan, intraoral scan, and then from that.
So you take an intraoral scan, you'll have a digital wax up created.
Okay.
You'll take so that scan goes to the laboratory. You'll take a CBCT scan. You can layer the wax up onto the CBCT scan. All digital.
There is no wax involved.
You can then use the scan to upload to your implant planning software. You can then create a stent on top of that. You can then get the stent milled, and from that you can get the guided drill kit that just goes through the hole.
That sounds a bit easier than
It's much easier.
Yeah, so easy in terms of the planning, in terms of the steps involved.
But the steps are still, you still need to know everything.
Absolutely.
You still
and the pitfalls.
exactly.
I guess it's still you're still supervising something that's been planned, but you need to make sure that
but it just means that if you're starting off implant dentistry, that you're doing things in the right way. You're not putting an implant into bone and then figuring out, how do I now restore this tooth?
Right, fair enough.
You're doing the prosthetic side first.
And we see all sort of implant cases that get referred to us, sometimes from abroad. We've got some interesting full mouth rehabilitation that went on in some places where normally people go on holidays and then they come back. We welcome all those cases. It's quite interesting stuff. Without being too specific, what sort of horror stories have you seen recently when it comes to all these, so screws everywhere and patient in tears trying to fix this mess? I mean,
there's patients with huge amounts of pain, swelling,
that sort of possibly turkey teeth. Let's we see few of those.
You get your turkey teeth, and it may
not just turkey.
It's a very broad generalization.
Yeah, just a term that people
you can get it from anywhere. You can even get it from this country.
Absolutely.
And it's again understanding what you're doing. So, linking single unit, linking multiple crowns, invading biologic width.
Be a trademark of that sort of dentistry.
I saw one the other.
Why do you think it happens? I'm sure everybody listening knows
it happens.
Just poor margins. But
sometimes the margins are great, and it's just that they've linked them all and they're uncleansable, and that causes so much pain to people. And in my opinion, I think this might be the wrong thing to say, but I think they link it because if in case one tooth fractures underneath, the bridge is still
in place.
It's fine. It's in place.
Right.
Very
difficult to fix, right? These sort of problems. We've got a few cases.
And then the other ones we get are someone's been to B&Q and put different screws in.
The dubious quality of some of these implants is just...
they look like screws from B&Q, some of them.
Yeah, it's very difficult
until
to find
you see the OPG. You don't realize that these things can go on.
Yeah, I think I can see like a little video coming up with some of these cases, and I'm sure whoever is listening will find them very, very interesting. Is stuff that, as an endodontist, I don't really know the ins and outs of dental implant, but even to me, it
I mean,
looks
sometimes
like
we
a little bit
wonder
of
how
picks
this
and
happened.
mix,
Yeah.
you know, and
It's
you
literally
chuck
pick and
screws,
mix screws different in different places.
different lengths, and some in bone, some not in bone. Um, we talked a lot about implants, but one thing that, as an undergraduate, I used to really be scared of was an art that I think is becoming less and less used in general dentistry, which is dentures, right? Removable dentures, full dentures and removal, which I know that the full dentures are, especially the lower
I still
ones
get
with no
scared of
bone,
them.
they are your passion. That's what you hope to see in your diary every day. Give
I'm
me
still
a
scared
lower
of-
full
I'm
denture.
still scared of
makes
them.
my day. So, what's the denture situation at the moment? We're avoiding them as much as possible and trying to get up to
I
offer
mean,
implants as much as possible, or
yeah.
there is still a place.
There is a place for dentures, especially with implants. So it's been a consensus now for a few years that the gold standard in the lower dentition for replacement of teeth is 2 implants and an overdenture. And actually, it makes a massive difference compared to a lower complete
So patient
conventional
satisfaction
denture.
is-
It's through the roof.
Right.
50% of people that have a lower conventional denture made don't wear it. The study has shown that. So,
Wow.
the difference between the retention of a lower, don't get me wrong, there'll be some patients who will have suction, but majority it moves around. And then if you utilize 2 implants and some locators, the difference is huge.
Yeah, and
It's
it's
huge.
also, relatively speaking, not absurd in terms of expense, because
No,
it's 2
comparatively,
implants
it's-
unrestored, if you like, and
2
a
implants
denture
and a
is a
denture.
right?
Yeah,
So
we,
it's
we,
something
we,
that-
we do a lot of them. We
Right.
do a lot of them, and patients, majority of the time are, if not all the time actually, with implant retained dentures, are super happy. They come in thinking there will be dentures. They are dentures, but they don't look like them. They fit perfectly. They can eat
Your
majority of
impression
things.
taking for denture or implant retained denture, is it still sort of non-digital?
I mean, I still do it non-digital.
Right.
But I'm sure there's a lot of people out there will be shaking their heads at me and saying, "No, we make them through a digital scan," which is
great.
fine.
Which
Yeah,
is great,
It
yeah.
can be done. I'm just a bit more old school with my dentures.
enough,
I mean,
fair
I will take digital scans for chrome dentures, and I'm happy with that. But when I'm doing conventional fill arch cases, full arch removable cases, I will still take an impression.
But also, you hear loads of, you see on social media sometimes dentists that say, well, I had this patient, I made a denture, I did my best, but the patient came back, gave me the denture back, they're not using it, they want a full refund. So it sounds like dentures are sometimes a recipe for patient dissatisfaction, I guess,
Yeah.
expectation management, that sort of thing. How do you manage that?
It's
Let's
really
say
difficult to manage that.
conventional denture for lower arch.
It's all about consent. It's all about sitting there with the patient and understanding, look, this is not like your teeth. And
I'm not going to be happy with this.
you have to get it into their head that it will be good,
Right.
but it's going to take adaptation.
Right.
And it will take maybe months to adapt to.
Right.
And they're not going to act like your own teeth. And they're going to wobble about, especially if you're making a complete denture against natural teeth, because
Right.
you're going to get tipping forces. And I almost say it to patients at every appointment, just to confirm this is going to be how it is. And they get fed up with me telling them, but at least I'm drumming it into them.
Yeah.
Letters to explain it, show them things,
So taking the time, even in writing,
Yeah,
just
and you will still get some patients that, and that's like anything, you will still get some patients that don't accept that.
Right.
But at least you've done everything you can for the majority of the patients to kind of understand what's going
never
on.
skip that step.
Yeah, you have to with dentures because
And I know we just touched on informed consent that you just mentioned, and this is something that I often mention during my lectures for endodontics. I do believe, as part of the consent process, to have something in writing, a summary of what has been discussed. And going back to what we discussed before about the NHS, I fully understand how difficult that is, if not impossible. But it's something that really helps the patient to understand. And 99% of patients are absolutely
I
reasonable.
mean, even
as
if
long
it's
as they understand
something
what they are.
generic, just saying, look, it's going to take you this amount of time, up to this amount of time to get used to the dentures. You need to take them out at night. They will cover the roof of your mouth. The lower one will move around. You know, just a bog standard. It's easier now with technology that you can have that already there and just they can squiggle and sign. But yeah, I get that on the
It's
NHS.
a little
more,
part of the not enough on his own.
No, but at least it's something.
Does help with everything else with that. Now, in terms of moving on to still prosthodontics, but something that I see sort of regularly is I get lots of referrals from referring dentists where there's dubious restorability. And I think that is something that happens to every dentist every day. Say, hey, I'm not sure what's the best option here. Is it root canal and crown, or can I put a crown? Have you got like a quick tip how to assess restorability for the patient that comes through the door and it's borderline?
Well, just as a standard, if you had an emergency patient come in, pain management, see what pain are they getting, if they're getting any at all, what's the type of pain, is it coincident with reversible pulpitis, irreversible pulpitis, basic starting point. Have a look in the mouth, see how much structure there is, because the main thing about being able to restore a tooth is having enough structure to it.
How much? A millimeter, 2 millimeters, 4 millimeters, half a millimeter. How good are you with your...
Yeah, that's not the easiest question to answer, but we know 2 millimeter ferrule for anteriors, 3 millimeter ferrule for posteriors, if you're going to be looking at posts, for example. But with bonding these days, it's a little bit less
crucial, maybe.
Crucial, yeah. We know with conventional crowns, metal ceramic crowns, we wanted good taper, you know, height of tooth structure. With the bonding onlays these days, you know, you can do tabletop onlays.
Wow.
So it is different, but what you're looking for is making sure, and you know, that you can be able to restore this tooth adequately, get a good seal.
So what do you normally do?
So PA, make sure that the caries or the fracture is...
Take all the caries out.
Well, before we take that out, do an X-ray. Make sure we're not impinging upon the biologic width. Anyone that doesn't know, 2 millimeters above the crest. If you impinge on the biologic width, you're...
So that's the first thing that you assess. You assess on PA, so bone level, see where you are.
See what do you from an X-ray whether it's even restorable, because sometimes you
don't even take it further.
Then you have a conversation with the patient. You say, look, I may be able to fix this tooth. We need to remove the caries and have a look. And if they are a decent patient, they will understand that, and you explain to the patient, look,
I say reasonable rather than decent, but I know what you mean.
Sorry,
I know what you mean. No, it's fine.
You remove the caries and you have a look and see what's left. If you can get a matrix band around that tooth, the tooth is restorable for sure.
That's it.
If you can get a composite down to a seal or an amalgam down to a good seal, then you can restore that tooth.
That's it. Right.
If it's a very deep carious lesion, I might turn around to the patient and say, look, we're going to leave it like this, period of a couple of months, 2 months, 3 months, just to see whether you develop any symptoms. Bring them back, EPT.
So we're talking about vital, symptoms-free teeth.
And then come back and do the vitality assessments and then put a crown on the tooth. If we're impinging biologic width, you can consider crown lengthening.
On that note, so there are, I guess, certain scenarios where crown lengthening might not be a good idea. I've seen a couple of cases. I was wondering what you think about it. So, situation where tooth can be saved, heavily restored, borderline, can be saved with a little bit of crown lengthening, but prognosis long-term dubious, and removing bone might sort of make an implant later on not great. How do you manage those sort of situations?
Well, the key thing is you've got to look at the patient. So you've got to check the age, first of all. Like if a patient is 50 years old, 8 millimeters of bone height to the sinus floor, versus a 70-year-old with 10 millimeters of bone height to the sinus floor, you might say, well, look, you know, it's not a nice thing to say, but the patient's got less longevity. Life expectancy is less. If we can get 10 years out of doing a bit of crown lengthening and a crown, and we remove 1 millimeter of bone, we've still got another 9 millimeters there to place an implant. If we're going in the realms of, if we take bone away here and we're going to lead to a sinus lift, then you may say, well, actually, in this case, we'll take the tooth out and put an implant. If you're crown lengthening and you're going to start taking bone around the furcation of the tooth, you're going to reduce the prognosis even more. So you don't want to be doing
So
that.
crown lengthening is not necessarily always the answer.
No,
So
crown
you
lengthening
just
is not
make
always
sure.
the answer. You've got to look
And I
at
guess
what
even
else
more in
is
the
around.
lower jaw, right? So
Yeah,
ID canal and
all of
that
that
sort
stuff.
of things.
You don't want to do crown lengthening and then find you take the tooth out and now you've only got 6 millimeters of bone to the ID canal.
And the bone, the tooth with a dubious prognosis might not last as long as the patient expects.
So it's a good modality, but you need to use it in the right context.
It makes perfect sense. Now, thank you very much for all these sort of technical and clinical tips. And but I would like to move on to something that I think all of us we can relate to, because we talked about implants, denture, demanding patients, consent, and make dentures not wobble too much. But after all these challenges, we go back home, and you have got a young family, and I think you're
See the bags under my eyes.
sleep deprived, and I think lots of listeners will relate to this. You know, I believe that we do a very demanding job in terms
Yeah.
of being focused and delivering what patients expect, but only dentists understand this. You know,
Yeah.
but non-dentists, they think, well, you've been like drilling and filling
they
all
say,
day, so
you know,
what are you
people
moaning
that
about?
don't work in healthcare. Oh, you got a 9 to 5 job. What are you talking
That's
about?
it. Yeah, I've been doing building work. But do you find a little challenge sometimes to just stop the day in life one, which is life at the dentist, and
I think
start the day with very young
With
children?
what I do, it's different.
Right.
You know, it's like what you do. Okay. I go home and I write letters and I write treatment plans and I do this and that. For a general dentist, that may not be the case. So yeah, I struggle with a work-life balance. I'm also a bit stupid in terms of I work 5 days a week rather than taking a day off and doing an admin day to do all of that stuff.
You love dentures too much. That's right.
I'm not sure about that. I love you too much. But yeah, so sometimes, yeah, it's just challenging. It's 3-year-old, 5-year-old. My wife's a dentist. It is challenging because we both
Do you talk
work so hard.
teeth at home?
She hates it.
She hates it.
I
Right.
will come home and I will unload a little bit. She just will stop talking to me.
Yeah. Also because you talk crowns and
Yeah,
dentures and
she's-
things.
she's
She's a
talking about-
periodontist, by the way,
She's
for
talking
the
about cutting
listener.
gums and stuff.
So specialist, exactly. So well, if there is no pink stuff, I'm not interested. You know.
But also, she's more of a morning person and I'm more of an evening person. So
Right.
Yeah.
Yeah.
So it kind of works out in some ways.
Yeah. It must be very challenging.
But
both
yeah,
of you.
some days I get home and kids have gone to sleep, and I try and keep my weekends for.
Okay,
for them.
so is that the important part of your
Yeah,
recharging?
so
I
I
was
used
about
to
to ask.
work when my older one was born, and the little one then born afterwards. I used to do some Saturdays, and I stopped it because I wanted
Yeah.
to take the kids to
There
football
is a balance,
and
yeah.
you know, take them tennis and this and that and the other.
That's how you switch off,
Yeah,
right?
so that's
Time with the
where I
kids.
switch off. And then in the week, I then don't mind working and doing my letters till 10 o'clock and things like that. That's
That's
fine.
part of the job.
weekend, I don't want to be doing, you know. So
Couple of quick fire wrap up, just coming to the end. So a couple of questions, like short and straight to the point. Composite or ceramic for you?
Costas will hate me. Ceramic.
Ceramic. Okay.
Unfortunately, there's not just a one-word answer, but I'll leave it.
Of
I'll
course,
leave it.
just leave it. It has to be controversial. This is meant to upset people or make people love you more. Who knows? So screw retain or cement retain?
100% screw retained.
Oh, right. That's really interesting. Yeah. Why? Any particular reason?
It's easier.
Retrieve. Okay. Easier to.
It screws down. You put a composite on top, and then there's no issue. Periodontists like me because I'm not putting cement everywhere.
Yeah.
Retrievability is there. I mean, I had a case the other day. Upper right one had an implant. Upper right two fractured. It's a screw retain crown. Unscrew it, scan it, screw it back in. 2 weeks later, screw a new one in.
Sounds difficult. I'm sure it's easy.
No, but if you imagine compared to a cement
absolutely.
retain,
No,
you're
it's-
trying to find that screw in whatever else.
So most underrated prosthodontic skill.
Most underrated prosthodontic skill.
Denture making.
No, because I think most dentists think that prosthodontists only make dentures. So
Right.
I don't think that's an underrated.
But actually, you try to avoid them as much as possible.
I think probably aesthetic cases.
Right.
Because when people talk and hear about prosthodontics, they think rehabs, they think
Yep.
tooth wear, they think
Yep.
crowns, they think dentures.
Yep.
But actually, if you look at Costas, for example, He's a prime
That's Kostas
example of
Karagianopoulos for the listeners.
he's
Is
a
the
prime
first
example.
episode of the
Yeah,
podcast.
but he's
so
a
go and
prime
listen.
example of someone that's brilliant at cosmetic work.
Gifted.
Yeah, composite bonding. We all do all of that, and I think that's something that a lot of dentists don't quite realize.
I think I know the answer of this one, but one book or course or mentor that shaped you.
I would not have said this 4 or 5 years ago,
Right.
but today I will. Costas.
Kostas Karagianopoulos is one of the prosthodontists
Yeah.
at UKDS in St Albans.
One
amazing.
thing about him was that he's happy to teach.
Yeah,
And
he's happy to share knowledge.
his knowledge of composite work and tooth wear and aesthetic work and shade taking is second to none.
Yeah, it's excellent. One thing you would tell your VT year self, so young Pranay doing VT. So one good advice to give to young Pranay.
Practice more.
Right.
Spe-
Okay.
I would have liked to actually probably have spent maybe another year as an associate dentist.
Okay.
Just to hone those skills, because what people forget is that, okay, I went into prosthodontics, but from that general practice, I understood endo, I understood perio,
Yeah.
I understood oral surgery. You understand when
You understood
can do
endo. That's why
things.
you stopped doing it. Is that
Yeah.
now
Well, you
I
know-
understand
you
this.
understand when you can do something, when you can't do something.
Yeah,
So
yeah.
when to take a CBCT scan, all those
It
stuff.
also is the love that you develop for a
Yeah,
particular
so
branch
I
of
think-
dentistry. So I think it's really important,
Yeah,
right?
when I was in VT,
Do
my
things you
biggest thing
love.
was I want to stop doing endo.
Right. Yeah.
But actually, now thinking back, just hone those skills a little bit. What makes you a better dentist?
Yeah, just to break it to you here, you're not gonna do endo here. I'm just joking. Right. Okay. Well, today we cover the whole prosthodontic spectrum from implants to dentures, restorability to real life, and huge thanks to Pranay for sharing so openly with us. So if you enjoy this conversation, subscribe and share it with a colleague who's exploring the next step in their dental journey. I'm very grateful for the time that people spend with us, and we will have other episodes with other amazing people involved in dentistry. You can follow us and news of future episodes on our Instagram and LinkedIn and Facebook and all the various social media. You will also find some tips and tricks, as we call them. I think Pranay has got some in the pipeline. We've got a library. So if you go on our website, you will see a page with a library. So it's all free. So you can just go there and have a look at some cases that we like to share with you guys. And as usual, we do some events and lectures where we like to share knowledge, and there is no second end. So it's all to get together and talk dentistry and get better together. So thank you very much for listening, and I will see you in the next episode.
Thank you, guys.